morning. We can hear you and we can see the screen.
Okay, so today we are going to look at the clinical anatomy of the inguinal region, and we are going to start right away. I told you to read about it, and I'm sure some of you try to do so. Okay, so just a minute.
Yeah, I think you're muted. So we are seeing the cursor moving on.
Okay, I was muted accidentally. Okay, I didn't know. All right, so I was saying that the inguinal regions, there are these areas on either side of the body that separate the lower abdominal wall from the thigh, and we said that they are marked by a skin crease, or what we call the inguinal line, a line that is created as a result of the underlying inguinal ligament, a ligament that we know that runs from the axis down to the pubic tubercle, and our region also is situated between these two bony ligaments, all the way from the axis down to the pubic tubercle. And I was saying that the axis is just, in some people, can be appreciated by a dimple.
No, excuse me, sir. We are not getting you.
So up to now, you can't hear me? Because initially, yes, I had muted myself accidentally, but right now, can you hear me?
I'm hearing now.
Because initially I had muted myself, but I later unmuted and I began afresh. So on this slide, I was just showing you where the Inguinal regions are found, and I have already talked about that. And we say that they are part of the regions of the abdominal wall that we talked about last time. And we say they can also be called iliac regions or the groins. Okay, we talked about that last time. Then I was saying that these regions are important anatomically because they are structures that are going to be going through downwards towards the external genitalia in both sexes, and then from the external genitalia upwards towards the abdomen, as we shall see. Then it's important clinically because it's a weak spot through which hernias can easily occur. Hernias that we shall later call inguinal hernias. Okay. Within the inguinal region, we have an oblique passageway where those structures will pass, the structures that will be running down to the genitalia or from the genitalia up into the abdomen. Those structures are going to be going through what we call the inguinal canal. It's an oblique passageway, as you can see. It's not straight, it's oblique, it's slanting from the lateral side to the medial side. It's around 3 to 5 centimeters, on average 4 centimeters long in adults. And it's going to extend from what we call the deep inguinal ring to the superficial inguinal ring. So ideally, you can say the deep inguinal ring is the entrance point into the inguinal canal, and this is the exit tunnel from the canal. So you can see that is your inguinal canal. It's going to be situated just above the inguinal ligament. We have seen that the inguinal ligament extends. The canal is inguinal ligament. Picture, it's the same story. Here you can see superficial inguinal ring. The deep, well, we can't see it here, but we can extrapolate it to be around here because we know that it's situated lateral to this vessel here. Which vessel is this? Anyone to remind us? Which vessel is this? Anyone can speak.
Femoral artery.
Is this the femoral artery?
Epigastric artery.
Okay, I think let me see hands. I see people who are speaking. By show of hands, what is the name of that artery? Yes, Agnes.
The epigastric artery.
It's not called the epigastric artery. Yes, Kauchi Godfrey. Kauchi Godfrey. It's not called the epigastric artery. You call it in the. You use the right name. Yes, Shirat.
It's called the superficial.
Shirat, you're breaking. You said it's called.
It's called the superficial epigastric artery.
No, it is not the superficial epigastric artery. Agnes, you want to try again? Agnes, you're on the right track, but you missed something.
It is the inferior epigastric artery.
Is the inferior epigastric artery a branch of what? A branch of, yes, Shirat, a branch of?
It's a branch of the femoral artery.
Shirat, I think you missed our session last time. It's a branch of, yes, Tracy?
It's a branch of the external iliac.
A branch of the external iliac. Last time I told you, this whole vessel that you see here, above the inguinal ligament, it's called the external iliac. Below the inguinal ligament, it's called the femoral. So you can see our vessel, it's coming from the external iliac. So we know that the ring is just lateral to the inferior epigastric artery, as we shall later appreciate. So below the inguinal ligament, we have a very big space there. That space, you can call it the subinguinal space, the space between the ligament and the hip bone. Okay, this is the hip bone. That space, the subinguinal space. Within this space, there are many structures. Laterally, we can see that there is a muscular compartment, a compartment that will house or that will contain the iliacus and the psoas major, plus the femoral nerve. Okay. Then medially, there is another compartment or a portion that will contain blood vessels. And you can see our femoral artery here. You can see the femoral vein. Okay. And then you can see medially there is a passageway that we call the femoral canal. Okay. So below this, the inguinal ligament, medially, we have those vessels and the passageway that we are calling the femoral canal. All these, they are wrapped around by what we call the femoral sheath. Okay. So in green, what you can see is the femoral sheath wrapping around the artery, the vein, and then medially, this medial compartment of the femoral sheath, it's a passageway that we call the femoral canal. Okay. So that's a subinguinal space. So the femoral sheath, it's just a connective tissue which is going to be wrapping around our vessels, the femoral artery, the femoral vein. Okay. As we have seen here, this one in green is the femoral sheath. Okay. So it's going to be wrapping around the femoral artery. I don't know, there is someone who is not stable. Nampera Shadia, please. Nampera Shadia and Nakabuya Agnes. Kindly control your devices, please. Okay, so I was saying that in green, what we see here is the femoral sheath. It's just connective tissue that is going to wrap around the artery, the vein, but also medially, the sheath has a passageway that we are calling the femoral canal. So here I was showing you where the sheath is going to come from. The sheath is going to be formed by the fascia transversalis. Remember the fascia transversalis that we talked about as we are covering the abdominal wall? So part of it extends downwards, okay? And then posteriorly, there's what we call the fascia iliaca. The fascia iliaca, it is this fascia that is going to be on top of the iliacus muscle, this fascia here. So these two are going to continue downwards to wrap around the femoral vessels to form our so-called femoral sheath. Okay. This femoral sheath, we have said, it has compartments. The lateral compartment, that's where the artery is situated. The middle compartment is for a vein. And then the medial compartment is called the femoral canal, and it's going to contain lymphatic vessels and some lymph nodes. Okay, so those are the compartments of the femoral sheath. So you can see it's like a sleeve wrapping around the vessels and the lymphatics. This image showing you the same story. The whole of this that you see here is the femoral sheath. The lateral compartment has the femoral artery. In the middle has the femoral vein. The medial has the lymph nodes and some lymph vessels, and it's called the femoral canal. This femoral canal, usually it's going to be almost closed by some connective tissue. Of course, it's closed to prevent structures from the abdomen from easily going through it. Okay. But of course, if the pressures if the intra-abdominal pressure gets so high, it's possible for the intestinal coils to force themselves through the femoral canal. This is mostly seen in ladies, in women, because women have wider hip bones or pelvic bones. They are wider, and since they are wide, obviously the canal is also going to be bigger as compared to the men, and that's why such scenarios of intestinal structures forcing themselves into the canal, such scenarios are common in the women because they have a wider femoral canal. And that type of hernia, we call it the femoral hernia. Okay, and in that hernia, basically intestinal structures force themselves through the femoral canal. And the hernia sac, this lower end of the hernia, this is what I'm calling the hernia sac. This hernia sac is going to be situated lateral or inferolateral to the pubic tubercle. Okay, and that's a bony landmark that can be used to differentiate femoral hernias from inguinal hernias. In femoral hernias, the hernia sacs are going to be situated lateral to the pubic tubercle. The pubic tubercle can be felt, can be palpated in a patient, and if the sac is lateral to the pubic tubercle, that is simply going to be called the femoral hernia. If the hernia sac is medial to the pubic tubercle, that type of hernia, it will be called an inguinal hernia. Okay, so if it's lateral, that's femoral hernia. If it's medial, that's an inguinal hernia. We're going to look at inguinal hernias later on, and we see how they can further be categorized. So in this slide, remember this. Femoral hernias have sacs that are lateral to the pubic tubercle, and we've said they are going to be common in the women. So as I have mentioned, for femoral hernias, the sac or the neck of the sac is going to always be below and lateral to the pubic tubercle. And usually patients that present with swellings in that area sometimes can be misdiagnosed. There are many things that can confuse you, thinking that okay, there are very many differentials or very many conditions that I can say may present in a similar way. Okay, we've seen how we can differentiate a femoral hernia from the inguinal hernia. Femoral hernias, they are lateral to the pubic tubercle. Inguinal hernias, they are medial. So, with that landmark in mind, you can easily differentiate a femoral hernia from an inguinal hernia. Okay. Then patients with lymphadenopathy, those patients can also present with swellings in the same nearly the same area, and usually lymphadenopathy means enlargement of lymph nodes. We know that in this area we have what we call inguinal lymph nodes, and if a patient has got an infection or injury on the body, let's say on the lower limb, usually this patient will present with swellings in this area, and that is called lymphadenopathy. Lymph nodes are swelling or enlarging because of an ongoing infection or injury on the lower extremity. So how can you differentiate this from these two? Patients with swollen lymph nodes, when you palpate the lymph nodes, you can feel them moving. I believe most of you have experienced swollen lymph nodes, let's say in the armpits. Let's say if you have an injury on the arm, you can feel some swollen lymph nodes in the armpits. Or let's say if you have a sore throat, you can feel some swollen lymph nodes around the neck. So usually whenever you try to touch those lymph nodes, they are slightly mobile. So that can be used here to differentiate enlarged lymph nodes from hernias. Okay, but also simply if a patient has got any form of hernia, if this patient, let's say, coughs, we know that the pressure inside here is going to build up and that swelling is going to bulge, okay, whenever the patient strains or coughs. Okay, so all that can help you to differentiate hernias from lymphadenopathy. Some patients are going to present with what we call femoral artery aneurysms. What is an aneurysm? What is an aneurysm? By show of hands. I talked about this as we are looking at connective tissues. Yes, Katusime Juliet.
Aneurysm, it is a dilatation of a blood vessel or a weak point.
So an aneurysm, that's an abnormal dilatation of blood vessel. Mostly these are going to be arteries because they are high pressure blood vessels. And in a patient with a femoral artery aneurysm, or in a patient with an enlarged femoral artery, how can you differentiate such a patient from these other patients here? The patient has a femoral artery aneurysm. How can you differentiate that from these other scenarios? Anyone who can tell us? Anyone who can think and tell us? Okay, so such patients, remember these are arteries, and arteries are high pressure blood vessels, and if a patient presents with an enlarged femoral artery around this area of the femoral region, of course when you palpate that enlargement, it will be pulsating. There will be some pulses when you try to touch and feel, and that will indicate that this enlargement is because of an underlying artery. Okay, so if the swelling is pulsatile, that will be a confirmation that this patient is having a femoral artery aneurysm. Then lastly, there are patients that can present with swellings in this very area because of what we call a psoas abscess. A psoas abscess is just pus collecting underneath the connective tissue that overlies what we call the psoas muscle. Last time we looked at the psoas muscle, we say it's one of the muscles of the posterior abdominal wall coming from the lumbar vertebral bones towards the femur. And this muscle is going to be covered by some connective tissue, some fascia. And usually patients with extrapulmonary TB, we all know TB attacks the lungs, but in chronic states, this TB can extend and spread to different parts of the body. It loves to spread to the bones, and if TB spreads to the bones, those germs that cause TB can cause infection of the bone, and pus can build up within the bones, and this pus can easily track down underneath the connective tissue that overlays this muscle, and as that pus tracks down, it's going to fill or to accumulate within this femoral area here. Okay, so this patient will present with a swelling in that area, and you have to be keen not to misdiagnose and say that this patient has got a femoral hernia. Okay, and one way how you can differentiate these patients from the rest, of course you are not TB. These patients are going to be coughing. Of course, these patients are going to be on TB medications. Okay, that's why it's always good to know the patient history, because it can guide you in making precise diagnosis. So these patients are going to present with swellings in the femoral area, and these basically swellings that are containing pus tracking down from the vertebra. Okay, and that condition we are calling it a psoas abscess. Okay. All right, so let's look at how the inguinal canal develops in both men and women, because we know that it's present in all sexes. So let's try and see how it forms in men and how it forms in women. In men, the inguinal canal, it forms during the time when the testicles are descending. We know that testicles or the testes, they develop in the abdominal cavity, close to the posterior abdominal wall. Okay, actually close to your kidneys. So usually those testicles have to descend. Okay, and what makes the testicles to descend, it is the fetal testosterone hormone, the hormone that is being produced by the very testicles of this growing fetus. So that hormone induces testicular descent. So for the testicles to descend, there's a structure that has to form, a structure that has to pull it down. That structure is called the gubernaculum. The gubernaculum is just a connective tissue that will attach to the lower pole of the testicle, and inferiorly it's connected to the area where the scrotum will be, the area where the scrotum will form. So this gubernaculum will pull the testicles down, of course on either side, and as the testicles are being pulled down, they are going to remember they are situated, normally they are situated onto the posterior abdominal wall behind the parietal peritoneum. Okay, this one here. So as the testicles are being pulled, they are going to come along with this parietal-peritoneum that you see here. They are going to come along with it. You can see it. Okay. In this other image, you can see it here. So as they are being pulled downwards, they are going to come along with the parietal-peritoneum, and they are going to invade the layers of the, they are going to invade the layers of the abdominal wall, and they are going to be pulled down to, or within the scrotal swellings, or the area of the future scrotum. Okay. So after the testicle descending down, what will happen? This extension of parietal peritoneum that you see here, it's going to disappear. The upper part is going to disappear, or the proximal part is going to obliterate, but the distal part is going to remain. This distal part that is remaining, it's going to form what we call the tunica vaginalis, a double-layered sac that wraps around the bigger part of the testicle. It's going to be okay. So it's going to be wrapping around the testicle, the bigger part. Then the proximal portion is going to be lost. The proximal portion of that extension of the parietal peritoneum, an extension that you can call the processus vaginalis. That extension there, it's also called the processus vaginalis. It's going to extend down, and the lower part will disappear, and the upper part is going. So the lower part will remain to form the tunica vaginalis. The upper part is going to obliterate or disappear. You can appreciate that as the testicles descend, our inguinal canals are going to be forming, and as you can see here, they are going to be forming in the process, during the process. Okay, so that's the area of the inguinal canal that is forming as the testicles are being pulled down by this gubernaculum. So after the gubernaculum pulling the testicles down into the scrotum, there's some small piece of the gubernaculum that remains. This small piece will later form what we call the testicular ligament, or some sources can call it the ligament of the scrotum. The ligament that's going to be tethering your testicle to the scrotum, okay, so that your testicle can be firmly fixed in its anatomical position. Okay, so that's how the inguinal canal forms in the main. It forms during the process of testicular descent. Okay, and we have explained that. This image showing us the same thing. You can see that as the testicles descend, as we said, the parietal peritoneum is going to be pulled down, and after the testicles reaching their definitive site, after the testicles reaching their definitive site, we say the proximal part of the processus vaginalis has to disappear, and the distal part remains, and it will later become the tunica vaginalis. Okay, and we say that as the testicles are being pulled down, they are going to come along with their vessels. These are the testicular vessels. They are going to come along with the vessels, with the sperm duct, and all these are going to be contained in a muscular structure, a muscular tube that we shall later refer to as the spermatic cord. A cord that is going to be within the formed inguinal canal. It's going to be lying within the formed inguinal canal. Okay. So In the adults, we can appreciate that this is the spermatic cord that you see here. It's going to be containing the layers of the abdominal wall. Okay, remember, because we said as the testicle is being pulled down, it's going to pull or to come along with the layers of the abdominal wall. So those layers, as they are coming down with the testicle, they are going to be arranged in a form of a tube, a muscular tube that we call the spermatic cord. So what you see here, this whole tube is the spermatic cord. It's going to be made up of muscles and fascia, and it's going to contain the vessels of the testicle, the artery and the veins, and also it's going to contain the sperm duct, or what you can call the ductus deferens. Okay. Same thing here. This is your spermatic cord, the content that's going to be within the inguinal canal, a canal that has two rings. We have the internal ring, which is the entrance, also we call the deep inguinal ring, and then the exit that we call the superficial inguinal ring. Okay, there was a hand from someone. Yes, Okelo. Okelo.
Good morning, Master. Good morning, Master.
Good morning.
Thank you so much. I would like to inquire at what age does Inguinal canal close? Because I remember when we were young, we used to play, like, you used to find that you don't have your testicles. But when you have grown, they don't hide. So at what age does that canal close? Thank you.
I beg your pardon, Okelo. You said that when you're growing, you didn't. I beg your pardon. I didn't get something there.
My question is, like, at what age does Inguinal canal close? Because when we were young, like during cold time, you used to, when you touch your scrotum, you find the testicles are not there, the testes are not there. So, but now when we've grown, even if it's cold, the scrotum will just shrink, but testicles will remain there. I just want to know at what age does it close? Or it remains open or it closes?
The inguinal canal never closes. It's a passageway that allows structures to pass through, so it's always open. Okay, you've seen the rings. There's an internal ring and a superficial ring, so it's a passageway. It's a tunnel for structures. So I can't say that it's going to be closed. What you're talking about, you not feeling the testicle at the early at the infant stage when it's cold. Remember, whenever it gets cold, these testicles are going to be elevated. We are going to let us see a muscle that we call the cremaster muscle. Whenever it contracts, it elevates the testicles, and when you probably when you touch, you may feel as if the scrotum is empty, but it's not empty. It's just that the testicles have been elevated during the cold. Okay, so usually in young ones, when you palpate the scrotum and you don't feel anything like the testicle, that's a sign that's a reason to worry. Okay, because when you don't feel the testicle within the sac, it's an indication that there may be an undescended testicle in this young one. Okay, that's usually the case. Whenever I don't feel anything like a testicle in the scrotum, it's a case of cryptorchidism or undescended testicle, as we shall see later. But in normal cases, In normal cases, when it gets cold, the scrotum, the scrotum will shrink, and the testicles, they are going to be elevated. And remember, they are going to be small, so they will be elevated slightly, and when you touch, you may not feel anything, but they are there. Okay, so that's how I can reply to you, Gideon. Okay, so we are going to say more about that as we talk about cryptochidism. I'll throw more light. Okay. Okay. Right. So actually, it's what we are going on now. The condition that I've been talking about, undescended testicle. This is called cryptochidism. We've seen that the testicles normally have to descend down into the scrotum. What makes them to descend is the fetal testosterone hormones. Okay, and there are some growth factors also that will aid in the descent. So if they are not sufficient enough, it's possible for a baby to be born with either both testicles not in the scrotum or one not in the, when one is not in the scrotum. In either case, if let's say both are not in the scrotum or one is not in the scrotum, like in this case, that condition will be called cryptochidism. This undescended testicle can be anywhere within the abdominal cavity, within the inguinal canal, as you can see that within the abdominal cavity, inguinal canal, or in this suprascrotal area. In most cases, this undescended testicle is going to be in the inguinal canal. That's why when you receive, let's say, such a patient, and let's say you palpate in the scrotum and you are feeling nothing, you're feeling nothing wiggling within, you feel no globular structure within, there's a possibility that there is an undescended testicle. And as a sonographer or radiographer, you obviously have to scan the inguinal canal. In most cases, you will see the testicle there in the inguinal canal. That condition is called cryptochidism. I didn't write it here, but it's cryptochidism or undescended testicle. It's here, cryptochidism. Okay, so these babies are not going to present with any symptom. The only thing is that the scrotum will be empty. That's why after birth, usually midwives have to palpate the scrotum to see if they are feeling any testicles there, to rule out cryptochidism. Usually these babies, they have to be given synthetic drugs that contain testosterone to induce testicular descent. Those drugs can induce testicular descent, but in other cases, these babies can also be operated so that this testicle can be dragged down into the scrotum. If this condition is not managed, these patients, once they reach their reproductive age, there's a higher chance that they may be infertile. Because remember, it's just one testicle that is in its right position, and you know that testicles have to be in the scrotum. They're not supposed to remain in the abdominal cavity because of the high temperatures within, because of the metabolism. Okay, so they have to descend to the scrotum to be free from the high temperatures in the abdominal cavity. So if one is not descended, of course it won't be producing viable sperms, and the little sperms that will be coming from this may not be enough, and that may account for male infertility. That's why they have to be managed after birth. In women, The inguinal canal is also going to form during the process of gonadal descent. Within the women, the gonads, we know that they are the ovaries. They're also going to form close to the posterior abdominal wall. They are going to form close to the posterior abdominal wall, and they are going to also be pulled down by this fibrous structure that we call the gubernaculum. So this gubernaculum, it's going to pull the ovaries towards the pelvic cavity, and the gubernaculum, after pulling the ovaries towards the pelvic cavity, or during the process of pulling the ovaries, same thing is going to happen. The parietal peritoneum is going to be dragged down, okay, and as it's being dragged down, it's going to form what we call the processus vaginalis, and this processus vaginalis is going to be pulled down towards the inguinal region and to create what we call the inguinal canal. Of course, after all this process, after forming the inguinal canal, the processus vaginalis has to disappear, has to be lost. In the men, we said the distal part remains intact and forms the tunica vaginalis. But in the women, the processus vaginalis has to disappear completely, normally. The gubernaculum, this fibrous structure here, it's going to differentiate into two things. Number one, part of it will form what we call the ovarian ligament. That ligament, those ligaments that you see there, those ligaments that help to connect the ovaries to the uterus, those are the ovarian ligaments. And then part of the gubernaculum will form what we call the round ligament of the uterus. A ligament that normally resides within the inguinal canal, passes there to come and attach the labia majora. Okay, so those are the two derivatives of the gubernaculum in women, and this can help you understand that within the women, instead of having the spermatic cord as a content of the canal, we shall have the round ligament of the uterus. Yes, it's called so because, of course, it curves around to enter the canal and attach at the labia majora. It's a very important ligament that will help in maintaining the normal anatomical position of the uterus. We know that the uterus normally it's going to be bent anteriorly over the urinary bladder, and that bend is created by the pulling action of the round ligament of the uterus. Okay, normally the uterus has to be in that anatomical position. So that is the round ligament, content of the inguinal canal in women. That round ligament, you can also see it there. It extends all the way from the uterus to the labia majora. Okay, and you said it allows the uterus to bend anteriorly, and that's the normal anatomical position. Okay, usually the uterus has to be stabilized in such a position by very many ligaments. There are many, this is one of them, and those ligaments, whenever they weaken, this uterus can lose its position and it can abnormally descend into the vagina, a condition that we call uterine prolapse. Then, always during pregnancy, we know that the uterus enlarges upwards, and whenever it bulges upwards, of course, it's going to pull the round ligament, and that's why usually ladies feel pain around the groin, simply because of the stretching of the round ligament as a result of the enlargement of the womb. As the uterus or as the womb enlarges, this is also going to be stretched, causing pain around the groins. It's a normal thing. Usually happens in most ladies. We said that the uterus has to be kept in position by many ligaments, and once those ligaments weaken, for example this, once it weakens, it can contribute to what we call uterine prolapse. Okay, the uterus is not supposed to be positioned vertically in the pelvic cavity. It has to be bending in anteriorly over the urinary bladder. So if the ligaments weaken, for example, in mothers who have given birth to many kids, mothers that are of older age, these ligaments are going to be weak and can lead to uterine prolapse. It can partly descend into the vagina. That is uterine prolapse. Then we've said that normally, as the ovaries are being pulled by the gubernaculum, the parietal-peritoneum is going to be pulled downwards, and that portion of the parietal-peritoneum that will be pulled downwards to create the inguinal canal, we said it is called the processus vaginalis. Okay, and we said that this has to disappear normally. Okay, and this processus vaginalis in women, it can also be called the canal of Nack, and we've said that it has to normally disappear or obliterate between 8th month of gestation and between 8th month of gestation and first year of life. That's when it has to disappear. Normally it has to disappear, as you can see here. It has to obliterate or disappear normally. If it remains patent or if it remains open, you can guess what can happen. It's possible for fluids from the abdomen to enter into this patent canal to come and overfill the tissues around the labia, and that condition will be called hydrocele. Okay, it's possible for the intestinal structures to herniate through and come and overfill the area around the external genitalia. Okay, and that will be called hernia or herniation. So normally it has to disappear. If it first disappear, such consequences can arise. So for example, we've said herniation. It's possible for herniation to arise if at all the canal of Nack or the processus vaginalis fails to disappear. It's possible for structures to herniate through. It can be intestinal structures. It can be the ovary and the fallopian tubes. They can herniate through the canal of Nack to create a swelling around the groin, and this kind of herniation is common in young girls because it's congenital. It's occurring because of the failure of disappearance of the processus vaginalis, so that's why it will present more in the young. And these young girls are going to present with painless swelling around the groin or in the labia majora, and that swelling is going to be prominent when these girls cry or strain or chronically cough. That swelling is going to be more prominent because as they cry or strain during coughing, there's going to be increased intra-abdominal pressure that will force the structures to extend more into the canal of Nack, resulting into prominence or more bulging of this area. So all these are possibilities, okay, and that's why always receive such patients, you have to scan them so that you can confirm whether there are some herniated structures within the labia majora or within the groin. All these are possible cases, and there are many. Okay, it's possible to have structures in the groin or within the labia of these young girls. We said also it's possible for peritoneal fluids to enter into the spaces around the or within the labia, and we call that hydrocele. We know that hydroceles are more seen in men, but women can also present with hydroceles. And these hydroceles are going to occur as a result of failure of disappearance or obliteration of the processus vaginalis after formation of the inguinal canal. As simple as that. Okay, and this can also be confirmed by ultrasound. In this animation, I had, I think, something small to show how the inguinal canal forms. Let me try to upload it very fast so that we can see how the canal forms. It's a 3D animation that can give you clear perspective on how it forms. So let me hope I don't know if it will be playing that side. I think it's playing. Is it playing?
The inguinal canal is a passageway through the abdominal wall that develops in both males and females. In males, proper development of the inguinal canal is an important event for the subsequent descent of the testicle into the scrotum, from its initial site of development in the abdomen. Testicular descent takes place in two phases: trans-abdominal phase and trans-inguinal phase. The trans-abdominal phase is a passive process during which a band of mesenchyme, known as the gubernaculum, appears to tether the testis to the scrotum. The testis, which initially lies on the dorsal abdominal wall, develops between the peritoneum and the rest of the body wall. Between 10 and 15 weeks of development, the abdominal cavity enlarges, causing the anchored testis to be drawn downward to the mouth of the deep inguinal ring. During this descent, the testes travel in a lateral to medial direction. The transinguinal phase is an active process that takes place over a couple of days between 25 and 35 weeks of development. A finger-like evagination of peritoneum, called the processus vaginalis, pushes its way through the tissues of the developing abdominal wall. This evagination follows the course of the gubernaculum and acquires sleeve-like coverings of tissue corresponding to the various layers of the developing abdominal wall. These layers, which develop into the transversalis fascia and the internal oblique and external oblique muscles, follow the processus vaginalis and become the layers of the spermatic cord, the internal spermatic fascia, cremasteric fascia, and external spermatic fascia, respectively. The leading tip of the processus follows along the gubernaculum and enters the scrotum. The testicle, together with the ductus deferens and testicular vessels, then follows. The testicle is able to enter into and move within the sleeve-like layers of the developing spermatic cord surrounding the gubernaculum and the processus vaginalis by compressing the tube-like processus. The proximal end of the processus vaginalis normally disappears. The distal tip survives and becomes the tunica vaginalis. The remains of the gubernaculum form the ligament of the scrotum. Female fetuses, the processus vaginalis develops to create an inguinal canal, but the descent of the ovary stops in the pelvis. The processus vaginalis disappears, leaving the remains of the gubernaculum to become the ligament of the ovary, and the round ligament of the uterus.
Okay, so that was something, some 3D animation that can make you always remember how the canal forms. Okay, so we can continue. I think the screen is back. Yes, Brian?
Sir, you
Yes.
talked about hydrosil and you explained that hydrosil is more common in young babies who are below 1 year. But we already see hydrosil in adults and in babies who are above 1 year. So what if this process vaginalis causes at 1 year and we see hydrosil occurring in adults, then what is always the problem, or where does that fluid come from if this process vaginalis always grows?
Okay, so just like how you can hit, let's say you hit your arm somewhere, or you fall on ground. Usually that part that has been injured can accumulate with fluid, okay, because of the inflammation that occurs in the injured area. So just like how fluid can accumulate in any other injured part of the body, when the testicles are injured, let's say in sportsmen, what will happen? Those layers of the tunica vaginalis, they can secrete fluid in large amounts to fill the space within them. And if that fluid is in excess, it can lead to an enlargement of the scrotum, and that is always seen in older patients. So hydrocele can either be congenital or acquired because of that reason. There is trauma to the testicle, it can lead to enlargement of the scrotum because of the increased inflammatory fluid or serous fluid within the space between the two layers of the tunica vaginalis. Is it okay, Brian?
Yes, it is okay now.
All right. Okay, so the structure contents of the inguinal canal in the men, we've appreciated that we have the spermatic cord. In the women, we have the round ligament of the uterus. Okay. Additionally, in both sexes, there is a nerve that we call the ilioinguinal nerve. It's going to innervate the external genitalia. Okay. When you touch your scrotum, you can feel that touch because of the ilioinguinal nerves. When you touch your labia, you can feel that touch because of the ilioinguinal nerves. So they innervate the external genitalia, but they also pass through the what? They pass through the canals to reach the external genitalia. Okay. So some bit of detail on the spermatic cord. The layers of the cords can further be seen here. Remember, your abdominal wall had what? It had the external oblique. Beneath that, we have the internal oblique. Beneath that, we have the transversus abdominis. Okay. So as the testicles descend, you said some of these layers of the abdominal wall are going to be they're going to extend to enclose this tube that we've called the spermatic cord. So to be specific, the external oblique muscle and its aponeurosis will contribute to what we call the external spermatic fascia, which will be the external layer of the spermatic cord. Of course, there is skin and some fat, But beneath that, we have the external spermatic fascia, which is a continuation of the external oblique muscle aponeurosis, as you can see. Then deep to that, we have what we call the cremasteric fascia and muscle. These are going to be extensions of the internal oblique muscle. If you see the internal oblique muscle here, some fibers are going to extend downwards to give rise to what we call the cremasteric muscle. Okay, some internal oblique aponeurosis can also extend to give rise to the fascia that we call the cremasteric fascia. So the outer layer is the external somatic fascia. As we go deep, we have the cremasteric muscle and fascia, as you can see being outlined here. Okay. Deep to that, we shall have what we call the internal spermatic fascia. The internal spermatic fascia, it's going to basically be a layer that will be formed as a result of the downward extension of the transversalis fascia. The transversalis fascia, remember it is that fascia that was beneath the transversus abdominis muscle. Okay. To be specific, the fibers of this muscle don't extend down. Remember, these fibers are oriented horizontally. They're not slanting, so obviously they won't extend down. Okay, so it will only be the fibers of these other muscles. But for the transversalis abdominis muscle, these fibers won't extend down. What will be extending down? It will be its fascia, the transversalis fascia. It will extend down and become the internal spermatic fascia, which is the innermost layer of the spermatic cord. So from outside or from outwards, we have the external spermatic fascia. Then deep to that, we have the cremasteric muscle and fascia. Deep to that, we have the internal spermatic fascia. Those are the layers of the spermatic cord. These layers extend to also become layers of the scrotum. These very layers will also be the layers of the scrotum down here. Okay. Then you can see deep to the internal spermatic fascia, you can see our tunica vaginalis. This was the distal portion of the processus vaginalis that remained. Okay, and it's a double-layered sac. Just as you remember the pleura, the pericardium, they were double-layered sacs. This is also a double-layered sac. Okay. The inner layer is the visceral layer that is close to the testicle, and then the outer layer is the parietal layer that is close to the layers of the scrotum. Between them, there is a space or a cavity that will always contain fluid, and this fluid is going to be produced by the cells that line these layers. Okay, and that fluid is always to cushion the testicle from external injuries. And we said that whenever there is so much trauma to the testicle, like in sportsmen, the fluid can be produced in excess amounts, and once it builds up here, it will end up resulting into enlargement of the scrotum. Okay, so we've talked about the cremaster muscle. It's remember a downward extension of the fibers of the internal oblique. It's very important. As I explained earlier on, it's important in allowing testicular elevation during coldness, so that your testicular temperatures can be kept in the normal range. That can allow spermatogenesis to always go on. These muscle fibers, they are innervated by the genitofemoral nerve. The genitofemoral nerve, it's a nerve that comes from that's part of the lumbar plexus, and it's going to come from L1 and L2, and it's going to innervate the cremaster muscle, the muscle that will always allow testicular elevation during cold environmental conditions. You can see that the scrotal sac, okay, the scrotal sac is going to have two compartments. There's a compartment for one testicle, and there's a compartment for another. And these compartments are going to be created by this fibrous tissue that divides the internal aspect of the scrotum into two. This fibrous tissue is called the scrotoseptum. Okay. Externally, we see it as the scrotorrhaphy. When you look at your scrotosac, you see the scrotorrhaphy, but internally, it's a scrotoseptum that will divide the scrotosac into two compartments for the two testicles. Sonographically, this can be well appreciated when you put your probe on the scrotosac. You can see the two compartments of the scrotum, okay, each for one testicle. This is one compartment, that's a testicle within. Of course, remember we said there is normally fluid within the tunica vaginalis, okay. Then on this other side, you can also see a testicle within this within this compartment of the scrotal sac. These compartments are divided by our so-called scrotal septum. These are the layers of the scrotum that you see here. These are the layers of the scrotum. Okay. The spermatic cord contains many things. There's a lot of things that are going to the testicle and leaving the testicle. For example, blood vessels. We have the testicular artery. It's going to be a direct branch of the aorta. It's a direct branch of the what? Of the aorta, and you can see it here. It's going to come off and go through the spermatic cord to reach the testicle. Okay, so testicular arteries, they are contents of the cord. The cremasteric artery, it's an artery that's going to be arising from the inferior epigastric. Remember your inferior epigastric? It's going to give off the cremasteric artery, which will supply or nourish the cremasteric muscle and fascia. Okay, so the cremasteric artery, you can see it there. It's a branch of the inferior epigastric. Okay, we talked about this as an artery that supplies the lower abdominal wall. Comes from the external iliac, and before ascending, it's going to give off a branch that will enter the cord, the somatic cord, to nourish the cremasteric muscle and fascia. Then we have the artery to the vas deferens. The vas deferens is the sperm duct, and this artery is going to be a branch of the inferior vesicle. The inferior vesicle means urinary bladder. The inferior vesicle artery supplies the urinary bladder, and before going to the urinary bladder, it's going to give off the small artery to the vas deferens, and this small artery is going to enter the spermatic what? The spermatic cord. So the artery to the vas deferens, you can see it there, being given off by the inferior vesicle, sometimes the superior vesicle, but all in all, it's going to enter your spermatic what? Your spermatic cord to supply blood to the sperm duct or to the ductus deferens. Okay. Then we have what we call the pampiniform plexus of veins. These are networks of veins that are going to be draining blood from the testis, and they'll be pouring the blood in the testicular veins. These are quite many. You can see there are many networks. Okay, Kelo, please control your gadget. All right, so you can see this network of veins. These form the pampiniform plexus. These are going to be drawing blood from the testicle, and they are going to be carrying this blood upwards. They are going to go through the spermatic cord, as you can see, and after exiting the inguinal canals, they are going to form testicular. They're going to merge to form testicular veins. So on the right, these veins will merge to form the right testicular vein. On the left, they will merge to form the left testicular vein. The right testicular vein, it's going to pour blood directly into the inferior vena cava. I don't know what's happening today, but it seems many people are not settled, and this is affecting our time. Okay, so I was saying that the left testicular is going to join the left renal vein at a right angle, and this blood will enter the left renal vein into the IVC. Then this straight joins the IVC. Okay. So because of the fact that the left renal vein, the left testicular vein is joining this at a right angle, there's a higher chance that blood can easily flow backwards. And as blood flows backwards, it's going to overfill these veins, and this will it will make those veins to enlarge, and it will lead to a condition that we shall later call varicocele. Okay, so remember that. We shall talk about that condition later. So we've talked about the coverings and the contents of the cord. Okay, and this picture can summarize that. I don't want to repeat, but you'll go through this. These are the layers of the scrotum, and then up here we have the layers of the spermatic cord. Alright, so here you can see again the layers of the scrotum. We have the skin, we have the dartos, we have the external spermatic fascia towards the layer of the spermatic cord. It continues to the scrotum. We have the cremasteric fascia and muscle. These line the spermatic cord, but they also continue to form layers of the scrotum. The internal spermatic fascia was a layer of the innermost layer of the spermatic cord, but it continues also become the innermost layer of the scrotum. Then deep to that we have the tunica vaginalis, this double-layered sac that has the innermost layer, which is the viscera, and the outer, which is the parietal. And this is the cavity that contains fluid. Okay. There are a few clinical correlates that we have to talk about now. There's what we call the cremasteric reflex. The cremasteric reflex, it's a very, very important reflex, which is induced when or after touching or palpating the upper medial portion of the thigh of a patient. Once you massage that upper medial portion of the thigh, normally there will be some bit of testicular elevation. Why? That portion of the thigh, it's going to be innervated by what we call the genitofemoral nerve and the ilioinguinal nerve, remember. So once you massage that area, sensations are going to be transferred or transmitted by these nerves, and these sensations are going to be taken to the spinal cord, the first lumbar segment of the spinal cord, because that's where these nerves come from. Okay, and of course after these sensations are transferred to the spinal cord, remember it's a reflex. Okay, the information that goes triggers the feedback. So after the information reaching the spinal cord, feedback is going to be relayed through the motor component or the motor fibers of the genitofemoral nerve, and those motor fibers, they are going to stimulate the cremasteric muscle to contract, and once it contracts, the testicle on that side, it's going to be elevated. So that is the cremasteric reflex. It's induced by simply massaging the upper inner portion of the thigh. It's a small bit of animation here to show you that, so that you can remember. I always use these animations so that you can always remember. Okay, so it's going to show you the cremasteric reflex. Okay, let me scroll through. So
I am showing you the cremasteric reflex. This is called
Okay.
cremasteric reflex. Cremasteric reflex.
Okay, so it's a normal reflex. Usually, when that upper inner aspect of the thigh is massaged, there will be testicular elevation. It's a normal reflex. If the testicle does not elevate, or it's not elevated, it may be a sign that there may be some problem with the nerves themselves. There may be some nerve injuries, or there may be a problem with that segment of the spinal cord. So it's a very important neurological test to check the integrity of the first lumbar segment of the spinal cord and the genitofemoral nerves themselves. Okay, so that's the cremasteric reflex. Okay, so if it's absent, that would be a reason to worry. All right, so let's go on. There are some conditions that can cause testicular pain. There is what we call testicular torsion. There is what we call epididymitis, cause intense pain. And testicular torsion, you can appreciate it here. Normally, you can see that testicles are wrapped around by what? By the tunica vaginalis on the anterior end. This double-layered sac, okay? And we also know that normally testicles are tethered to the scrotum by the, which ligament is this? How did we call it? Anyone can speak. How did we call this? The ligament of the scrotum or the testicular ligament. So if there is, if the inferior portion of the gubernaculum disappears and there is no ligament, obviously, it can increase chances of this testicle to easily rotate, to rotate in such a manner, okay? And in such cases, you'll see that the tunica vaginalis is going to almost wrap around the bigger portion of the testicle, and the testicle is going to, there will be a high chance of this testicle to easily twist upon itself. It is not fixed. It is not fixed in position, okay? So in such scenarios, mostly in sportsmen, whenever, let's say there is some trauma to the scrotum or the testicle, it may increase chances of the spermatic cord to twist upon itself and the testicle also to twist upon itself, okay? And that kind of deformity or abnormality is called the Bell clamper deformity, because the appearance of the, or the position of the testicle within the scrotum is similar to the position of this part of the bell within the bell. So that's why it's called Bell clamper deformity. So occurring because of the failure of formation of the testicular ligament or abnormal attachment of the tunica vaginalis around the testicle. This predisposes to testicular torsion, and whenever there's testicular torsion, you can see that the structures within the cord, within the somatic cord, are going to be squeezed or compressed. Remember, we have arteries, we have a testicular artery here that has to nourish the testicle. It's going to be squeezed, okay? And that can lead to death of the testicular tissues or necrosis or ischemia of the testicular tissues. Then remember, we also have veins, pampiniform plexus of veins. They are draining blood. If they are squeezed, blood will not be drained from the testicle, and this testicle over time is going to slightly enlarge, okay? So that is testicular torsion. Usually it is diagnosed using Doppler ultrasound. Doppler ultrasound detects flow, okay? Detects blood flow. So if you scan that testicle that's affected, you can detect reduced blood flow or no blood flow within that testicle, because the artery has been blocked, so there will be no arterial blood flow, okay? This is a surgical emergency because the twisting of the cord blocks the arterial blood flow and can lead to death or ischemia of that testicle. Okay, and that's why it is a surgical emergency. This testicle can survive only 6 hours without blood flow. Beyond 6 hours, it will lose its function. That's why surgery has to be carried out before the 6 hours. So diagnosis sonographically has to be carried out early enough to prevent this complication of ischemia. Okay, these patients are going to be feeling so much pain, so much pain. So in this slide, what are we seeing? We are seeing the right testicle, the left testicle. Usually whenever there is a testicular torsion, we say the testicle the affected testicle is going to enlarge. As we've said, it's going to enlarge because of the blockage of the venous outflow. Okay, and you can see that here very well. Okay, then also the arterial blood flow is going to be not detected within this testicle because of the blockage of the testicular artery. So you can see the twisting of the cord also appreciated in this image, but also in this image. So this condition can be diagnosed simply by ultrasound. Okay. Then epididymitis, this is basically inflammation of the epididymis. Okay, and the epididymis, of course, we all know that it's that structure there at the posterior aspect of the testicle. There's a head, there is a body, and the tail. That's the epididymis. Okay, this view, you can also see this is the testicle, the head, body, and tail. Sonographically, of course, you can appreciate the epididymis very well. It's found at the back or the posterior aspect of the testicle. This is the testicle. This is the epididymis. This is the head. We have the body and the tail down. Okay. So in patients with the epididymis, of course, the epididymis is going to enlarge because of the inflammation. Because the inflammation is going to become enlarged. The head is enlarged here, the body is enlarged, but also there will be increased blood flow because of the inflammation that is going on. We know that whenever there is inflammation, the blood flow increases, and that can be detected and used to be confirm epididymis. Secondly, these patients with epididymis, even before a scan, you can easily tell they are going to have discharge coming from the penis because of the pathogens causing inflammation within the epididymis, resulting to pus. And this pus is going to be coming out from the penis. The pathogens that cause this condition, they are sexually transmitted. We have chlamydia trachomatis, we have the Neisseria gonorrhea, or these are the common cause of epididymis in young sexual active men. But also it can occur because of trauma to the testicle, trauma that can lead to injury of the epididymis. Okay, so that is the condition. Then there are some conditions that cause scrotal swelling. We have hydrocele and varicocele. I've already talked about these. And for hydrocele, it can be communicating or non-communicating. If there is a patent processus vaginalis, it's possible for fluids to extend from the abdomen down into the tunica, down into the cavity of the tunica vaginalis. And if that happens, that is called communicating hydrocele. Okay, this will cause enlargement of the what? Enlargement of the scrotum. It can be non-communicating, for example, in cases when there is injury, as I explained earlier. When there's injury to the scrotum, inflammation can cause increased buildup of fluid within the cavity of the tunica vaginalis. Okay, so that is a non-communicating hydrocele. The processus vaginalis is not patent. It fully obliterated proximally, and this fluid is not coming from the abdomen, but it's accumulating because of the trauma to the scrotum or to the testicle. So that is hydrocele. Here we are seeing a possibility of a hydrocele to occur concomitantly with a hernia. Remember, whenever there is a patent processus vaginalis, we said it's possible for intestinal structures to herniate through, and at the same time it's possible for fluids to go through and accumulate in the cavity of the tunica vaginalis. So it's possible for a patient to concomitantly present with both of these, and all this can be confirmed sonographically. So sonographically, here we are seeing a patient with hydrocele. We say that normally that fluid that is around there should be there within the tunica vaginalis, that fluid there. It should be there, but if it's too much, of course, you can appreciate that. Normally, fluid appears dark on ultrasound. Okay, so you can see excess fluid around this testicle. That's a confirmation of a hydrocele. These patients are going to present with a very big or enlarged scrotum on the affected side. Okay, then varicocele. So in varicocele, we say that these patients are going to present with enlarged, tortuous, swelling, pampiniform plexus of veins. Okay, and we said that this condition is going to be common on within the left testicle or on the left side. Why? Because the left testicular vein joins the left renal vein at an angle, so it's possible for blood to pour downwards to overfill the pampiniform plexus of veins and the testicle. So basically, that's why it's common on the left side. There are more reasons as to why it's common on the left side. I want you to find out. This is just one, but there are several reasons as to why this condition is common on the left side. So these patients are going to present with, of course, pain that is not so severe as compared to a patient with testicular torsion. But of course, there'll be some dull kind of pain sensation that will be felt when you touch the scrotum of this patient. Okay, so it's a vague, dragging, painful sensation. Sonographically, of course, these pampiniform plexus of veins can be well appreciated. These are the pampiniform plexus of veins. They are filled with blood, and this can be confirmed that it is blood by Doppler. Okay, this too much blood in the pampiniform plexus of veins can extend into the testicle and result into intratesticular varicocele. You can see the veins in the testicle, they are enlarged, that is intratesticular varicocele. If it's only the pampiniform plexus of veins enlarged, you can call that extratesticular varicocele. Okay. So, are we all still on the same page? Are we all still on the same page before we continue? All right. So, having mentioned all that, let's come back to our inguinal canal. We've appreciated where it is located. We've appreciated how it forms. We've appreciated the contents. Okay, let's come back to it. We say there's an inner ring or internal ring. We call it the deep inguinal ring. It's just lateral to the inferior epigastric vessels, remember. Then there is an external ring, or what we call the superficial inguinal ring, which is an exit from the inguinal canal. Okay, so that's the superficial inguinal ring there. Okay, then the deep inguinal ring, it is there just above the inguinal ligament, few centimeters above the inguinal ligament, above the midpoint of the inguinal ligament. Okay, that's where it's going to be situated. This canal has boundaries or walls that are easily appreciated here. You can imagine this canal to be like a box. Okay, for clarity, for you to understand the walls, you just imagine it to be like a box or a rectangle, as you can see here, with an anterior wall, with a roof, with a posterior wall, and the floor. So what is going to form our anterior wall? Our anterior wall is going to be formed by what? It's going to be formed by the external oblique aponeurosis and some part of the internal oblique muscle fibers. They will form the anterior wall. Then the floor, obviously, it's going to be formed by the inguinal what? The inguinal ligament. Okay. The curved surface of the inguinal ligament will form the floor of our inguinal canal. The roof is going to be formed by what? It's going to be formed by the internal oblique and the transversus abdominis muscles. Remember, these muscles, we said they are going to fuse to form a conjoint tendon. So that conjoint tendon is going to form the roof of our canal. Posteriorly, this canal is going to be bounded by transversalis fascia. Remember, beneath the transversus abdominis muscle, we have the fascia. So it's going to form the posterior wall. And that fascia, it's going to have, it's going to be the location of the deep inguinal ring. You can see it deep there, that deep inguinal ring there. It's a ring, that is within, that one there. It's within the posterior wall or within the transversalis fascia. Then the superficial inguinal ring, it's a ring on the anterior abdominal wall within the external oblique aponeurosis. That's the superficial inguinal ring. So once again, anteriorly, we have the external oblique aponeurosis and some part of the internal oblique fibers. The floor is formed by the inguinal ligament, that curved surface of the inguinal ligament. The roof is formed by those arcing fibers of the conjoint tendon. Remember, the conjoint tendon is formed by the union of the fibers of the transversalis abdominis, and the internal oblique. So those will form the conjoint tendon that will run above our inguinal canal. So those two form the conjoint tendon that runs above the inguinal what? The inguinal canal. Okay. Then posteriorly we have the transversalis fascia, and we say this transversalis fascia, it's going to be just beneath this muscle that we've called the transversus abdominis. And we said within the transversalis fascia, that's why we shall have the opening that we are calling the deep inguinal ring, where structures will pass to come out or to enter the canal and come out through the superficial inguinal ring. Okay. So once again, you can appreciate the conjoint tendon here. It's a structure formed after fusion of the internal oblique and the transversus abdominis fibers. And last time we appreciated that it's going to attach on the pubic crest. So it's going to form the roof of our canal. This is our canal. So the roof is formed by the conjoint tendon. Here we can still see the conjoint tendon formed by the transversus abdominis here and the internal oblique. The fibers of these muscles, the aponeurotic fibers, they're going to fuse to form the conjoint tendon, which will be the roof of our inguinal canal. Our canal is deep there. Okay. So those are the boundaries of the canal. Let's look at a few more points here. Normally, we say that inguinal canal is going to be a weak spot for herniations to occur. Remember, it's a passageway. Okay, so it's possible for structures to easily go through. You understand? But of course, anatomically, our body is made in such a way that there are factors that reduce occurrences of herniations to easily occur within the inguinal canal. Yes, herniations can occur when someone is exposed with intense intra-abdominal pressure. Herniations can occur, but to some extent, these herniations can be prevented by the following mechanisms or factors. Okay, let's talk about one by one. We have what we call the flap valve mechanism. This can be explained by these pictures. Remember, our canal is not a straight passageway. Okay, it's an oblique passageway. It's an oblique passageway. It's an oblique passageway, as you can see here. We saw that it has an anterior wall and a posterior wall. Okay, it has an anterior wall and a posterior wall. So whenever the intra-abdominal pressure increases slightly, this pressure can make the posterior wall to come close to the anterior wall, and as these two approximate, the canal is going to be closed. The canal is going to become almost closed after these walls are approximating. The canal is going to be closed. So because of the fact that these rings are not in a straight, in the same plane, whenever the muscles contract, these walls are going to nearly come towards each other, and that will prevent likelihoods of herniations to occur through this inguinal canal. This is the deep ring, this is the superficial ring. Pressures can cause these walls to approximate, closing the oblique passageway to reduce incidences of herniations. Okay, that's one mechanism. Secondly, we have what we call the ball valve mechanism and the slit valve mechanism. You can use these images to understand. The slit valve mechanism can be appreciated here. Remember, we have the superficial inguinal ring. This superficial inguinal ring, it has the lateral and the medial cross. Whenever the external oblique muscle contracts, okay, what happens is that these pleura are going to approximate to each other, and that can somehow allow closure of the superficial inguinal ring. Once it closes, the chances of herniations to occur are going to somehow be reduced. That's a slit valve mechanism. It's a slit that closes. The superficial inguinal ring, it's like a slit that closes. Then the ball valve mechanism can be explained in these images. Remember, we have our muscle that we call the cremasteric muscle. It's a muscle that wraps around the spermatic cord and extends to enclose to be part of the layers of the scrotum. So whenever the internal oblique contracts, remember the internal oblique is the one that gave rise to these fibers of the cremasteric muscle. Whenever it contracts, what will happen? Remember, muscles contract towards their origin. It will contract with fibers pulling upwards. Whenever fibers pull upwards, your cremasteric muscle is going to also contract in the same direction, pulling upwards. Okay. Whenever it contracts, it will basically pull upwards, and it will somehow result into closure of this ring. Whenever it contracts upwards, it will somehow reduce the gap. Okay. Whenever it contracts, to reduce the gap, it will plug the superficial inguinal ring, reducing chances of herniations occurring. So that's the ball valve mechanism. Then last, you have what we call the shutter mechanism. So your congenital is like a shutter that can easily contract downwards to close to result into closure of the or narrowing of the inguinal canal. Remember, the conjoint tendon is going to be formed by the internal oblique and the transverse abdominis muscle fibers. So whenever they contract, what will happen? this conjoint tendon, it's going to somehow narrow down the canal, but also the deep inguinal ring. And that somehow, as you can see, reduces the space in the canal and limits chances of herniations occurring. So normally, anatomically, that's how your body is prevented from, or that's how herniations are prevented from occurring within that weak area that we've called the inguinal canal. Okay, so let's finalize by talking about these hernias. Hernias that occur in the groin or in the inguinal regions are simply called inguinal hernias, and they are going to be contributing 75% to all abdominal hernias. There are many abdominal hernias. There are what we call epigastric hernias that occur in the epigastric area, umbilical hernias that occur through the umbilicus, incisional hernias that occur in people who ever went for a surgery and maybe there is a surgical incision that was left. Okay, if it weakens, herniations can occur. So these are other types of abdominal hernias, but they're not so common. These are the commonest ones. These inguinal hernias are the commonest ones. They contribute 75% to your abdominal wall hernias. They are common in men, okay, because of the fact that men are exposed to activities that increase the intra-abdominal pressure, and that can increase chances of such herniations to occur. That's why they are most common in men. They are categorized into two, direct and indirect, and these can be appreciated one by one. First of all, why are they called direct and indirect? What do you think? Why are we calling them direct and indirect? One is called direct, the other one is called indirect. Why do you think so? Anyone? Anyone who can tell us why do you think they are called so? One is called direct, inguinal hernia, the other one is indirect. Yes, Godfrey.
For me, I think that one is called the direct and another one indirect because one might be acquired and another one is congenital.
Okay, so you can see that these herniations are occurring in the inguinal region. Okay. Indirect, we are going to learn that it occurs when there's a weakening in the lower abdominal wall, and basically intestines are going to push through that weak spot to enter the inguinal region. Okay. In indirect, we are seeing that the structures are finding a path to reach the inguinal region. So it's indirect, it's not direct. In the direct, these coils are going to straightforward pass through the weak spot. But here they are going to take another path to reach the inguinal region. That's why this is called indirect, but this is direct. Okay. So basically that's why they're called so. Let's now talk about each in detail. The indirect, we can see that it's the most common form. Okay. It's congenital in origin, meaning that it's occurring because of something that didn't happen during development. It's going to occur mostly because of failure of obliteration of the proximal part of the processus vaginalis. If it remains, if that proximal part remains, these structures are going to easily go through the what? That patent proximal portion and enter into the deep inguinal ring, okay, and then come out through the superficial inguinal ring. So that's why it's called. That's why we are saying that it's congenital in origin. And since it is congenital in origin, it's going to present more in the young ones. It's going to present in the young. We know that the deep inguinal ring is lateral to the inferior epigastric vessels, and we have said that in these hernias, structures are going to go through the deep inguinal ring. So obviously, from that point, you can appreciate that this hernia is going to be located lateral to the inferior epigastric vessels. These are the vessels. Okay, we have the artery and the vein, and our ring is lateral to that, and the hernia is going to be occurring through the ring. So that's why we are saying that this hernia is going to be located lateral to the inferior epigastric vessels, outside the Hessel-Bach's triangle. The Hessel-Bach's triangle, it's this triangle here. Okay, it's this triangle here. It's located in the inferior aspect of the abdominal wall, and it's bounded medially by the rectus abdominis, inferior by the inguinal ligament, laterally by the inferior epigastric vessels themselves. So it's a weak spot within your lower abdominal region, and herniations can easily occur through this triangle. But for our indirect hernias, herniations are not going to go through this weak area. The herniations are going to go through the deep inguinal ring, okay, through the canal, then through the superficial inguinal ring to enter the scrotum in men, or the labia majora in women. So that's the difference between the direct and the indirect. The indirect, we have said, those intestinal structures are going to go through the deep inguinal ring, which is lateral to these vessels and lateral to or outside the Hessel-Bach's triangle. So that's the path going to be taken by the coils of the intestines. Through the ring, through the deep inguinal ring, through the canal, through the superficial inguinal ring, through the patent upper portion of the processus vaginalis down into the scrotum in men, or the labia majora in women. So that is the indirect inguinal hernia. Okay. This image can further also show you the indirect. Okay. The coils are going to go through the deep inguinal ring, through the canal, to come out of the superficial inguinal ring to enter the scrotum or the labia majora in women. But we say they are more common in men, okay? And we said because men are exposed to activities that increase the intra-abdominal pressure, but also the inguinal canal is wider in men. Why is it wider? It's wider because it's going to allow passage of the spermatic cord. The spermatic cord is bigger as compared to the round ligament of the uterus. Okay, so since the spermatic cord is bigger, it's going to be more experienced in the men. Okay, their canal is wider as compared to the women. Okay, so that is the indirect inguinal hernia. We can see this image is further showing you the same. Herniation is going to occur through the ring, down into the canal, through the superficial inguinal ring, to enter the scrotal sac. So this is how these babies are going to present. They are going to present with a very enlarged scrotum. Very enlarged what? Scrotum. Okay. Then in the direct, this is acquired. It's going to occur through the Hessel-Bach's triangle. We said it's a weak spot, and as we age, that area is going to become more weaker. And if you are a person who is or let's say has lung disease like chronic obstructive pulmonary disease, when you're always chronically coughing, if you're a person with chronic constipation, such things increases the intra-abdominal pressure. When you add that to age, this area is going to easily allow or give away for the intestines to protrude through and enter the inguinal region. So these types of hernias are going to be medial to the inferior epigastric vessels. As you can appreciate here, these are the vessels. So they are going to be medial to the inferior epigastric vessels through the Hasselbalch's what? Through the Hasselbalch's triangle. Okay. So you can see this is your inferior epigastric vessels. Medial to it, you have the Hasselbalch's triangle. That's where the structures enter or protrude in direct inguinal hernias. Okay. In the indirect, the structures won't enter this Hasselbalch's triangle. These structures are going to pass lateral to the vessels to enter the deep inguinal ring and go through the inguinal canal to come out through the superficial inguinal ring to go into the scrotum or the labia majora in baby girls. Okay. So that these inferior epigastric vessels are going to be landmarks. Okay. Sonographically, when you reach the time of scanning for these hernias, you always use these vessels as landmarks. If the herniation is medial to the inferior epigastric vessels, that's a direct inguinal hernia. Okay. If the herniation is lateral, that's an indirect. But also, we've said in the indirect, in most cases, the structures are going to enter the scrotum in men and the labia in women. So the physical presentation can also guide you. Okay. In addition to this anatomical landmark, the physical presentation in this patient can. In the chat, someone talked about strangulation such a way. Remember, these coils are vessels. So such kind of and once those vessels are compressed, of the compression of it start undergoing necrosis, and once that happens, that kind of hernia, it can be called a strangulated inguinal hernia. If it's direct, that will be a strangulated direct inguinal hernia. If it's indirect, it will be a strangulated indirect inguinal hernia. Okay, so as long as necrosis happens, that term will be used. Okay, hope it's clear, Brian. I can see your question here in the chat. I was not seeing it earlier, but I hope that's clear to you. Brian, is it clear? Okay, so basically with that, we can mark the end of our coverage of the inguinal region. Do we have questions? Do we have questions? Do we have questions? Okay, so hope everything is okay. With that, let's end our session. We shall meet again tomorrow in the morning to cover the peritoneum, read about the peritoneum in detail. That's what we are covering tomorrow in the morning. So let me. Okay, Alex is asking about the gubernaculum and the processus vaginalis. Okay, Alex, have you been on and off? I don't know. I think you've been on and off. suppose I've been talking about. Okay, you go through the recording. If you get any challenge, or is my WhatsApp is open. So go through the recording. If there's any challenge, you can ask through my WhatsApp. Yes, Octavia. Let's hear from you lastly, then we close this. Octavia?
Yes, good morning, sir. Something I wanted to inquire is, can reducible hernias be collecting reducible hernias, or can only be done by surgery?
A reducible hernia, that's a hernia that, let's say if you exert manual pressure to these structures, if they can go back to their cavity, that hernia can be called reducible. Okay. If these structures can't go back to the cavity when you exert manual pressure, that's called irreducible. So your question is what? You're asking if they can be irreducible, can be corrected surgically?
Yes, I'm asking to know if it can
Yes.
be corrected without surgical means.
We've said the reducible hernias, it's possible to exert manual pressure, and when you exert such pressure, it's possible for these structures to go back to their cavity. But once this patient, let's say, is exposed to something that increases the abdominal pressure, these structures will herniate back through that weak spot. Yes, you can reduce manually, but it's advisable for these patients to be surgically operated to close those weak spots. Okay, because once they're exposed to situations that increase the intra-abdominal pressure, this herniation will occur again. So surgery is the end goal to manage such conditions. Is this clear, Octavia?
Yes, sir, it's clear. Thank you so much.
All right. Okay. So let me wish you a good morning. Let's meet again tomorrow.